So let me give a little bit of an introduction. Meenakshi Subbaraman is a program director and biostatistician at the Public Health Institute, as well as an instructor for the UC Berkeley School of Public Health. She received her MS in statistics from Stanford University and PhD in epidemiology from UC Berkeley. Her research interests include causal inference, recovery from substance use disorders, treatment for alcohol use disorders, cannabis and alcohol policy, and policies related to substance use during pregnancy. Before joining behavioral health and recovery studies, she worked with the Alcohol Research Group for 14 years, where she served as the Director of Statistical and Data Services for the last 2. We are so excited to host her today, so please join me in giving a warm welcome to Dr. Subbaraman.
Thank you so much, Shelby, for the introduction. Thank you all for joining me today on this big day. Hopefully I can give you some other things to think about. So today I'm going to be talking to you about factors that impact SUD recovery, housing, access, and effectiveness. Before I get started, I would like to acknowledge and shout out for the study team, our program director and the PI of several studies I'll be talking to you about today is Doug Polson. Amy Miracle is also one of our PIs and a senior scientist. She's the PI of the NSTAR study that I'll be starting off with. Liz Mahoney, our senior research coordinator and our study builder, and our collaborators, Sarah Zemore and Kat Monroe. Thank you to all of them for their collaboration on this work. So I'm going to be walking through 4 different studies that are related to recovery, housing access, and effectiveness. So these are 4 of the studies that we have going on at BHRS right now. We have other studies going on too, but these are studies on recovery housing. So our first study is a national study on addiction recovery residences, or NSTAR, and that's being led by Dr. Amy Miracle. I'll start off with that and give us a broad overview of recovery residences in the US. And then I'll go into a few of our studies on sober living houses. And these studies are led by Doug Polson, except for the last one, I'm leading that. And sober living houses, as I'll talk to you more about, are a specific type of recovery residence. And we have a few studies that are focused on, on sober living houses in Los Angeles. And my role on most of these studies is biostatistician. But like I mentioned, I am the PI, or hoping to be the PI of this last study on cannabis use. Okay, so to start off, for those who are less familiar with recovery residences, these are alcohol and drug-free environments, living environments for folks who are in recovery from substance use disorders, who want to pursue a program of recovery, and also live with others who are pursuing a program of recovery. Recovery residences go by a lot of different names. There's there's various structures that they offer, different kinds of services that they offer at different levels. But one of the common elements is that recovery residences require abstinence for those who are living there. So what do recovery residences look like? What do they do? So the National Alliance for Recovery Residences has outlined 4 general levels, and they're listed here in the columns, level 1 through level 4. And then we have some information about the physical structure, staffing, governance, programming, and examples that are listed in the rows. And so if we start off with level 1 houses, these are single-family houses without paid staff on site. They're democratically run. And an example of a level 1 house are Oxford houses. Lenny Jason at DePaul University, right in this area, he's done a lot of work on Oxford houses, one of the pioneers of recovery residence research. At level 2, again, we're still in single-family residences, but now we have paid staff. So we have someone like a senior resident or a house manager who is maybe paying reduced rent or being paid themselves for working there. At level 3, now the structure might vary a little bit in terms of the physical structure, but now again we have paid staff, we have maybe certified peer support on site, and more involved governance and oversight in terms of administration, licensing, things like that. And then when we get to level 4, we're basically at residential treatment. And so now we have paid staff that might include licensed staff, credentialed staff that are providing clinical services on site. One of the commonalities, or some of the commonalities that I want to point out across all 4 levels of recovery residences are listed in programming. So you can see that all levels do require some sort of substance use monitoring. This usually looks like drug testing, and we'll see some more data on that in a moment. All levels of houses also have house meetings, and so these are places where the residents are involved in the upkeep and running of the house. And also household chores. So again, that's related to the residents really taking responsibility and being active in the running of the household. So for our national study of addiction recovery residences, that's our NSTAR project run by Dr. Miracle. There's 4 overarching aims for this project. I'm only going to focus on the first one today, and that's examining the availability of recovery housing and characterizing where the residences are located. So for this study, there are some key design elements. So first off, the database and sampling frame development. So this is something that our team had to do ourselves because there was no list of recovery residences across the US. So we did a lot of searching. We looked at SAMHSA Treatment Locator, we looked at the National Alliance of Recovery Residences, we did a lot of Googling, and we came up with a list of more than 10,000 residences. I think it's actually about 13,000 at our last count. And I just want to emphasize this has never been done before and was particularly innovative about this project, that now we have a sampling frame and we can sample from that list of residences and survey them to find out more about what's going on in these houses. So we've done that. We created a survey with a team of experts. We refined the survey. We did a state stratified random sample where we sampled 838 residences out of that 13,000 and surveyed them to ask them more about their programs, about the practices, who's running the house, things like that. We also collected contextual data. So that's data about mainly at the county level. So what else is going on around the houses? So we collected things like substance use mortality, data on rurality, just to get an idea of what's correlated with what's around the house. So these data are preliminary. We have come up with sample weights since we made this table. And I will say that my understanding is when we weight the data, they are actually pretty similar to the unweighted data. So we are able to sort of say that these represent the universe of houses that we found. So what did we find? So so far, we're seeing that most of our, or not most, but about 2/3 of our houses were identified through Oxford Houses and through NAR. About 60% are for men only. We were pleasantly surprised that about 1/5 of the houses also accept children. So that was a little surprising to us, but I think encouraging. And about half of the houses had a capacity of 9 or fewer residents. So in terms of drug testing and the kinds of medications that are accepted in recovery residences, we found that almost all of the houses, so this is on the top line here, I'm sorry, this pointer is not working, but almost all of the houses required drug testing. And abstinence, so abstinence and drug testing. Those are the top 2 lines here. We also looked at acceptance of medication. So this is a big interest in our group. Do these residences accept folks who are on medication? So that's MOUD, medications for opioid use disorder, as well as MAUD, so medications for alcohol use disorder. And we can see that acceptance is pretty high. It's over 90% for those types of medications. But when we get to medications like stimulants for ADHD, we see a lot less acceptance. Now we're about half of the houses, less for opioids or narcotics for pain. And then, the circle didn't go in the right place. But what I would like to highlight here is that cannabis, the medical cannabis, was only 7%. So keep that in mind because that'll be relevant for one of our later studies. So as part of, and oh yes. Oh yeah, of course.
Is that 7% of people tested positive for it, or 77% of houses test for it at all?
So thank you for asking that. This isn't about testing. This is about the houses accepting residents who are taking those medications. Thank you for asking. And please, folks, feel free to interrupt me with clarifying questions. I'll also pause after each study, so if there are more involved questions, we can take a moment. So part of the NSTAR aims were also to map where are these houses across the US. So here's a map of the United States at the county level, and we can see hotspots of where there are more houses spatially than we might see if it were random. So we can see hotspots in the Pacific Northwest. We see one in Southern Florida. We see Ohio is like one big hotspot. And this might reflect communities that are friendlier to recovery housing. That's maybe because they have policies that are make it easier to open houses, make it easier to pay for houses, or there might be providers that have set up shop in a certain area and are just good at what they do. And so they've proliferated houses in a certain region. If you are interested in this map or other maps, we've overlaid this map with substance use mortality. We've overlaid it with rurality. So if you're interested in this, please check out our paper in drug and alcohol dependence. I'm also happy to share it with you. One of the other tasks that we've done with NSTAR is create maps at the state level. So because we're in Illinois, I picked our Illinois map here. And in the state of Illinois, we found 156 residences, which makes Illinois 44th out of 50 in terms of recovery housing availability per capita. So that's per 100,000 people. Coles County has the most recovery residences. I am not familiar with Coles County, but I heard Springfield is somewhere in this red hotspot region in the middle of the state. 80% of counties in Illinois don't have any recovery residents. I think this might be related to rurality. Again, I'm not that familiar with Illinois, but I believe much of it is rural, and we did find, as you'll see, that rurality was something that was also associated with the presence of recovery housing. Yes, please.
Are they required to live in the state where the housing is, or do you take residents from other states?
Yes, they take residents from other states, yes. That might depend on the house, but generally, yes, the residency is not a requirement. Any other questions?
How is the Medicaid billing or the payer sources for these
I had a feeling someone was going to ask me that, and so I checked with my colleagues this morning. So in our sober living house studies, about 5% of people are paying through Medicaid. So it is something that is possible, but my understanding is it's not easy, and that the rules vary from state to state what Medicaid will cover. Please.
Is there a majority source of funding then, or if it's only 5%
So that's, so for the national study, that's something that we're still looking into. Yeah. Thank you. So Before I move on from this state map, we did these maps for all 50 states. We have this kind of information for all 50 states on our website, nstar.arg.org. I encourage you to check it out. We worked really hard, and there's a ton of information at the state level. Okay, so like I mentioned, we also looked at county level correlates. So what factors are related to the presence of recovery housing at the county level? We found that residences were more likely to be in urban areas and in counties with higher substance use mortality. They were also less likely to be in lower socioeconomic areas. So that's if we looked at the presence of any versus none. We also looked at density, so it's a number of houses in a county, and found that there were more, that density was greater in urban areas and in areas with a greater proportion of non-white residents, but again, lower in lower SES areas. Although this was not part of our primary aims, we were also interested in the co-location of recovery residences and carceral facilities. Because I'm sure folks in this room know that substance use disorders and recidivism in the carceral system are linked. And we do, not from these studies, but from previous studies do support that recovery housing can be beneficial for folks who are leaving the carceral system. And so we wanted to know, are the houses located close to prisons? Are they nearby so that folks can get there easily? So this is an accessibility sort of question. And what we found was encouraging in that recovery residences were indeed often co-located with state and federal prisons and detention centers. So we looked again at the odds of any housing and at recovery housing density, and both were higher in counties with state prisons. So that was an encouraging finding, and the findings were similar when we looked at federal prisons. So to summarize what we have found in NSTAR to date, we identified more than 10,000 recovery residences. Again, I think that number is actually about 13,000. We saw that higher drug and alcohol-related mortality was associated with increased odds of having a recovery residence in that county. We think that's an encouraging finding that perhaps it suggests that the houses are in communities with greater need. But at the same time, we found some correlates like urbanicity and socioeconomic status that might suggest a need for housing in rural areas and in areas with lower socioeconomic status. In terms of future directions, what are factors that facilitate and inhibit access to recovery housing? That's something that we're very interested in looking at, especially among folks who are leaving the carceral system. And one thing that some kind of surprisingly comes up in review a lot is how are the houses affecting the surrounding communities? So there is, as you might imagine, a lot of NIMBYism around these houses. There's resistance to opening these houses in one's backyard. And so there is this question of how are recovery housing, well, how are these houses affecting the surrounding community? Yes.
Buying fairly quickly with, say, a wealthier one. And so far in the data, are you seeing anything where in those areas perhaps you're more likely to have a recovery house, maybe right at the cusp, versus if you have maybe we're very wealthy enclave that's very white, they're willing to have a Betty Ford center, but they're not willing to have other kinds of recovery houses. And I don't know so far, is that question you're asking, or if that's something that's maybe you want to tease out?
Yeah, we have not looked at that particular granularity, but that, I mean, that's a really interesting idea. Thank you. Any other questions about NSTAR? This is my blank slide to pause before we move on to our next study. Okay. Okay, so now moving on to sober living houses. So like I mentioned, we have right now 3 studies related to sober living houses. These are an example of a level 2 residence. They're particularly common in California. This photo here is of the San Fernando Valley. That's where I grew up and where a lot of our houses come from. So there's been a number of studies, too much to list on this slide, that have shown improvements among residents of sober living houses. So that's improvements in substance use, as well as psychiatric outcomes, employment, legal outcomes. And the recovery residences and sober living houses generally reflect the social model. Are folks familiar with the social model of recovery? Okay, so the social model of recovery is based on, I believe, 6 defining characteristics. And one of them is that knowledge of recovery comes from lived experience. It's not from a degree or from professional education. The experts on recovery are those who have lived it. So that's one of the defining tenets. Another is that a safe and sober living environment can protect an individual against relapse. And another defining characteristic of the social model that's particularly relevant for the next study is that everyone, all participants in the social model are help givers and help receivers. So that idea in particular is what led to the rationale for our next study. So the title of this study is Peer Helping, Retention, and Relapse in Sober Living Houses. And the aims that I'm going to talk to you about right now are to examine whether the social environment in the sober living house is related to helping behaviors and whether these helping behaviors are related to interpersonal benefits. So to do this, we gathered data from 205 residents living in 28 houses in Los Angeles. Our first step is to recruit the houses, and the way that we do this is through what's called the Sober Living Network. So we have a list of houses. The Sober Living Network is an organization that certifies sober living houses in California. So we were able to use their list and a sample from their list of houses in Los Angeles. We purposely sampled across quintiles of socioeconomic status so that we would represent diverse neighborhoods. And after we recruit the houses, we recruit residents from these houses. And the eligibility criteria is listed here. The most important one, they're all important, but the one that I have bolded is that they moved into the house in the past 30 days. And the reason that we required this particular criterion is that we want residents who are forming new impressions of the house and who might be more likely influenced, sort of a pre-post. And so, yeah, so we wanted newer residents that were coming into the house. So here's some very basic descriptive information about the sample. It's about 2/3 male. About half had were college graduates or had some college. About a quarter are parents, and an average age of 39 years old. So for the helping study, we did collect longitudinal data over 5 different time points. We measured the social environment using what we affectionately call the REES, or the Recovery Home Environment Scale, which I'll talk more about in a moment. We measured both giving help and receiving help in 3 different contexts, but today I'm just going to focus on giving help. So that was at the house in 12-step groups, and then generally to family and friends, and I'll go over these measures more. We measured interpersonal benefits using the CEST, and we tested associations between the REES and helping and the CEST using GEE models that adjusted for demographics, length of stay in the house, AA affiliation, use in the social network, and alcohol, drug, and psych severity. So here's our conceptual model from our grant. This is how we conceptualize the social model working in the recovery house. in the sober living house. And so on the far end, we have greater social model practices as measured by the Reese. We are hypothesizing that, yeah, I'm sorry that this doesn't work. So we're hypothesizing that greater social model practices are related to more helping. That's both more giving and receiving help. Today, we're going to focus on giving help. We hypothesize that those helping behaviors are related to increased inter and intrapersonal benefits. So we have different measures that we're going to be looking at in future analyses, but today we're focusing on peer support as measured by the CEST. And what we hypothesize or hope is happening is that these increased benefits are leading to greater length of stay in the house, and that in turn would lower relapse risk and lead to better functioning. So a little bit more about the measures that we use to look at this model. So the Recovery Home Environment Scale, this was developed by Doug Polson. There's 8 items to rate the social environment in the house. So these items are ranked by a scale of 1 to 5. And this includes items like, to what extent do residents provide emotional support to one another? To what extent do residents go to 12-step meetings together? To what extent are residents involved in decisions that affect the house? To measure giving help, we use 12 items, and we ask these items separately for the house and then generally for family and friends. So we got 2 different measures. And we also split these into what's considered instrumental help, so that's on the top box, and then the bottom box is emotional help. So instrumental help includes things like helping someone when they're sick or injured, helping someone run errands, helping someone when they needed a ride or needed a car. And then instrumental help includes items like helping someone when they're upset or depressed, helping someone by listening to their concerns, or helping by sharing your own experience. And so again, we ask these for people in the house, and then we ask them again about family and friends. Measuring help in 12 steps, we use different items that were specific to 12-step groups. So this was 12 items that were ranked from 1 to 5, and this included questions like, how often did you help someone by taking calls or spending time with the sponsee, by saying hello to a newcomer, by putting away chairs after a meeting. And then finally, we measured interpersonal benefits or peer support using the CEST. And so this was 5 items. How much do you agree or disagree with other clients at this house, care about you and your problems? You are similar to or like other clients at the house. And there is a sense of family or community in this house. So here's the results from our GEE models, looking at how the Recovery Home Environment Scale, so that's the REES, is related to helping. Those are our columns. So we have help given in the house, general help given, so it's family and friends, and then 12-step help given, and then our measure of interpersonal, which is the CEST. And so we can see that more social model activity as measured by the REES is related to significantly higher scores of giving help in the house, of giving help in 12-step groups, and higher scores on the CEST, so higher sense of peer support from the house. We then looked at how giving help was related to the CEST. And so this table shows results from 3 separate models that do adjust for all these covariates that are shown in this other table. I just wanted to simplify the table. So I'm just showing you how giving help is associated with the CEST here. So we can see that giving help in the house is associated to significantly higher scores on the CEST, as is giving 12-step help. And so to remind us of our conceptual model here, what I showed you on the previous slide was the first part of the path, that greater social model practices in the house are related to more helping in the house and in 12-step groups. So this first part of the path is supported by the previous slide. And now on this slide, what I'm showing is this second part of the path going from more helping to interpersonal benefits. So we see here that more helping, more giving help in the house, more giving help in 12 steps are both significantly related to higher peer support, interpersonal benefits. I want to acknowledge that we did not formally test mediation. I'm gonna do that when I get home, but that our results do suggest that a strong social environment might increase feelings of peer support via increasing helping among residents. We also saw that our findings are specific to giving help in the house and giving help in 12 steps. We didn't find any significant associations with giving help generally. So that suggests that the social environment is actually facilitating recovery-focused help, which was interesting. And we do think that this provides some preliminary evidence for how the social model is working in sober living houses. Practically, the REASE, the Recovery Home Environment Scale, does offer very specific activities that house managers can think about doing if they want to increase helping and interpersonal benefits among residents. So we went over those 8 items, but there were things like encouraging residents to socialize together, encouraging them to go to meetings together, and involving residents in decisions that affect the house. So again, those are specific activities that the REASE offers for house managers to think about. Any questions about our helping in sober living houses? Yes, Harold.
It's interesting, the 12-step finding is sort of interesting because I know those of us that do opioid use disorder work, we tend to be very skeptical of 12-step. And it is, the findings are a useful reminder that these things kind of need to be in conversation to evidence-informed medication treatment, and some aspects of the 12-step may go well together for a lot of people.
Yes. Thank you. Yes, and that is, although I didn't include this on this slide, it is common for recovery residences and sober living houses to encourage their residents to go to 12-step meetings.
To go to MOUD treatment when that's appropriate?
That is more controversial. Yes.
Did you look at any subgroup differences? Like I noticed when you're talking about including the houses that you have a good portion that were men only and a good portion that were women only. I was curious if any of these kind of helping behaviors or what the social model looks like and how this differed across some of those subgroups.
Yes, thank you. So we did start looking at differences in helping behaviors across demographics. So we did look at gender. I believe we looked at age. We also looked at race, ethnicity. We did find some demographic differences in terms of helping behaviors, both giving and receiving help. We're still working on that. This sample size is only 200 folks, so that does limit us. I also worry about the implications of, how do you write about some people are helping more, and where does that take you? But it's certainly an interesting question. Yes?
Piggybacking perhaps a bit on her question, is there anything about going into the granularity of the types of tasks, not just by gender or by age, but just in general, if the person is, and I'm making this up, more prone to not wanting to talk, but very willing to drive around and give somebody rides, are there any trade-offs with that particular behavior? I don't know if that would be something worth exploring.
Thank you. Yes, so we have qualitative interviews as well, where we did some deeper dives into what kinds of helping behaviors seem to be coming up when people are talking about it. Rides was a huge thing that comes up all the time. I mean, and this is LA too. So if you don't have a car, I mean, you're up the creek. So it's bad in LA. So, but yes, thinking about specific ideas, like in LA, yeah, a ride would be especially important if you don't have a car. So it's a great idea to think about more specific helping behaviors. Thank you. Any other questions about our helping study? We can talk about it more later too. Okay, so then I'm moving on to our next study on sober living houses. This was a multi-level analysis in which we were looking at how physical, social, and organizational house characteristics and the characteristics of their neighborhoods, how those were associated with outcomes among residents. So at the house level, we looked again at the social environment. We also looked at organizational characteristics, and one of the most innovative parts of this project was looking at architecture. So we looked at architectural characteristics of the houses, as well as neighborhood characteristics, like I mentioned. So we looked at alcohol outlet density, we looked at proximity of 12-step meetings and treatment services.